Thanks for joining me again, Francis. Today we were planning to, dive deep into the fascinating world of bone biology and the critical role our bones play in overall health. So I was hoping we could explore the sort of science behind how bones grow, how we maintain strength and repair, how the bones do that themselves, and then why osteoporosis, a condition that weakens the bones and increases fracture risk, is becoming, more prevalent, more common, but a lot more science is backing interventions on how to improve it. So Francis, hoping we could start off just talking about bone biology as a whole and maybe across our lifespan from childhood, adolescence into adulthood, and then into an older adult's health. Be able to talk us through that?
Yes. So the skeleton is something that's alive, which I think is really important to say first of all, because I think people think of it as like inert bone, but essentially our bones grow until we're fully grown, which is sort of probably about our 20s. And I guess people are aware when they're growing, you can sort of picture that the bones are like laying down new bone cells. But when you're fully formed, when your skeleton has finished growing, your bones are constantly remodeling. So there's little cells that lay down new bone and other cells that clear away kind of bone that has died. And I guess it's easy to picture that when you think of like your skin, because we can see it. I feel like it's easier to picture there. So people sort of know that you have like skin cells like falling off and they get replaced by new ones. So osteoblasts lay down new bone and osteoclasts break down old bone. And so when you're growing up and your skeleton's forming, that's obviously when you have the best chance of making your bones stronger because they're in their growth form. They're mainly made up of, most of the calcium in your body is stored in your bones. And they're also made up of collagen. And so you can imagine how when you're growing, it's super important to have heaps of calcium to facilitate that bony growth. And in order for your bones to become strong, they need loading. So they need to have enough loading to know that they need to be strong enough to withhold that strain on the bone from loading. So we know that it's basically like heavier, more intense forms of loading that are the most effective. So before you're 20, basically, you have the best chance of really building a really strong, solid skeleton. So it makes sense to eat lots of calcium and do lots of loading in that time. And obviously the other thing is just you need to eat enough food in general, and particularly protein, to cause that bony growth. So if you eat heaps of calcium but you're not eating enough, that won't be enough. You sort of have to get like eat a adequate diet, but particularly enough protein and particularly enough calcium. And I think it's important to know as well that bones are kind of hard on the outside, like a shell, and that's called cortical bone. And then on the inside, they're more spongy, and that's trabecular bone. And that bone, you could think of it like honeycomb, or I think of it like a lattice. And the trabecular bone can be particularly susceptible, I guess, if osteoporosis has taken place. So as we get older, that balance of the osteoblasts and the osteoclasts kind of laying down new bone and clearing away old bone, it can become imbalanced. And I think, I'm interested to get your thoughts, but I think that the reason for that is like if we need hormone balance for it to happen. We need the food that I already mentioned. You need enough load on the skeleton. So I'm guessing as we age, part of it is just the fact that hormone levels slowly decline. And so that's one thing. Maybe our activity levels like naturally decline a little bit. Maybe we're not consuming enough calcium, but for whatever reason, it does seem to be like all the things that we need for our bones to stay strong, they all seem to slowly decrease as we get older, and that balance is disturbed. And so it might be that there's not enough stimulus to lay down new bone, or there might be too much clearing away of old bone, but the result is that the bone becomes more brittle. And particularly in places like the spine, that trabecular bone on the inside gets thinner, and the honeycomb lattice can easily become sort of squashed down. So that's my understanding.
Yeah, no, I agree. Especially with the age component, just where we have estrogen as the main one for females, but other sex hormones. That's your major chemical imbalance that occurs, I guess, or the sort of production line for increasing new bone or laying down more bone. That's what does change with biological aging, which is inevitable. It's bound to happen for everyone, just like other organs have impairments as well. So unfortunately, bone is a critical one that does become more susceptible because of the hormonal changes. But like you mentioned, there's lots of other factors, dietary factors, exercise, many other impacts, essentially, or probably medication as well. They're the risk factors that we need to watch as we do age. If we go back to the osteoblast, osteoclast activity that occurs, my understanding is that when we, from a physical active point of view, we have osteocytes, which are the general receptors. So when you're doing exercise, if you're stimulating bone by, say, you're doing a curl, or you're doing a press, or you're doing some sort of movement, how our body detects it, or how the bone detects it, is those osteocytes. It's the receptors on bone, and it detects either impact, which is a vibration from an impact jump, or any type of impact, I guess. And then the other part's from when we do a movement, skeletal muscle contracts and it shortens, and then that pulls on the bone, which these osteocytes detect that physical stimulus. Because these osteocytes detect this, they then send a chemical reaction, I guess, in the body, which says there's been some movement here, and it can cause bowing or micro bending of the bone. And then this creates more of a further chemical stimulus, but then a physical stimulus to it as well. And then from that cascade, osteoblasts and osteoclasts are sort of more awake. In a childhood or adolescence, the osteoblast activity is a lot greater than osteoclast. So if you think about it from a ratio perspective, it might be 2 osteoblasts, the bone being laid down, and osteoclast is causing that remodel to get rid of that old bone. So in a childhood, adolescence way, I would probably say it's like 2 to 1. As we get to peak bone mass in our 20s, 23, 24, 25, for most evidence is what it's showing, starts to then level out at a 1-to-1 ratio where it might be maintained. So 1 osteoblast being laid down to osteoclast clearing. And this is where we get this continuing remodeling cycle going throughout our whole skeleton. So some people like to say our skeleton that we had as a child is never the same as what we had when we were an adult, because all this bone's sort of been remodeled and sort of wasted away and then rebuilt. But then as we get to that older age bracket, or we get into menopause or andropause or other sex hormone changes, we then see a decline in the osteoblast, and it might be 2 osteoclasts to 1 osteoblast. So now we're getting more bone depleted and wasted than what's getting rebuilt. So we'll probably dive into some of these risk factors, but if your osteoclasts are greater than osteoblasts, you're going to be in a constant state of depletion. And people doing exercise or taking certain medication that depletes bone further, you're in a constant state of loss, and you're trying to fight a battle in a loss. And it's just very difficult if you're not doing the right things from an exercise, nutrition, and probably medication point of view.
Yeah, and I find it interesting that it seems to happen. I suppose there's a degree that must be almost unavoidable because of the hormones. Yeah. I find that interesting.
Yeah. And you see thyroid issues starting from people in their younger 20s, and this can impact them later on in life. The other part I might mention is about, you probably know a fair bit about it, but bone stress injuries as well. This is where we want that bowing, or we want that bending in bone, and we're getting impacts. Think of a typical athlete who might have what they call shin splints, or pain in the tibia of the lower leg, and they're constant impact, and it's trying to remodel, but again, there's those little micro fragments in the bone, which is not wasting away, but it's just not repairing as much as it should. And this can go through another whole physiological process where we do elicit pain from that.
Yeah, and it's interesting that it's like you need a certain amount of bone deformation or strain on the bone to facilitate change. And it seems that really light doses of exercise, like walking, seems like it doesn't strain the bone or bend the bone enough to cause to that chemical reaction to lay down new bone. But then on the other hand, if you do something that causes a really high level of strain, like you say, you don't have enough time to recover from it, that can sort of be problematic as well. And I suppose there's also it comes into the risk factor as well, but people that who do endurance sports, for example, who are doing things that probably have a fairly high degree of strain on the bone, it's often interesting that their skeletons are not actually that healthy, because yes, they're putting a high degree of strain on the bone, but it's repetitive, which doesn't seem to cause the same chemical reaction. It's not as effective for whatever reason, and then not adequately recovering a lot of the time. And then they also have that low energy availability often, like they don't have enough food going in, or they might have the hormone changes that are making it more difficult to maintain their bone health. So it's interesting that, there are things that can happen to people across the lifespan that mean they're potentially at more risk later on, even though they're like might be really healthy and fit.
Yeah, and that's why I think some GPs may be scared to prescribe or promote certain exercises because they won't have the time to assess the patient's physical capabilities properly like we do. And so they might say, go walking or start swimming, but really this is someone who's at high risk of fall, and you tell them to go walking, it's probably going to put them in a further higher risk of fracture. So I think, you're right. It's a fine line between how much stimulus we need, which is going to then cause a positive bone remodeling response. But then sometimes our bodies are adaptive. It's like anything, certain medication, alcohol, like your body builds an adaptive response and it just gets used to it. So something low stimulating like walking or just a typical Pilates routine or swimming, cycling, all these non-weight bearing sort of low impact or low resistance exercises, our bodies get used to. Probably not going to have a positive effect on our bone health, but it might be good for psychological health or cardiovascular health.
Yeah, for sure. And I guess when people do actually have osteoporosis, I guess it becomes even more important figuring out what level they're at, where it's safe to dose something that's hard enough to cause bone strain that will stimulate remodeling, but not so high that it actually compromises the bone, because once it is weaker, there is that risk there. But I guess that's
I agree. And the other part to that, I was going to say the other part to the bone is considering muscular strain as well, because then if it's too much on the muscular area, we don't have the capacity to lift a weight or do a certain movement, then you can end up with the typical orthopedic injury. Then be more limiting. Yeah. Have you had much experience with that with your clients or your patients, where you're prescribing certain exercises and what you get is sometimes the patient's unsure if they can lift that weight, but then you've assessed them, you're like, no, I think you should be fine, and then you can build progressively.
Definitely the vast majority of the time the client thinks they can't lift a weight that they definitely can. So I often just think it's because I suppose people often aren't familiar with the fact that, like, if you stand inside a 20 kilo trap bar and hold each side and stand up with it and it weighs 20 kilos, that's really different to like lifting up like a 20 kilo grandchild or something. It's completely different. Like picking up a child is like biceps, arms, whereas picking up the trap bar, it's like perfectly shaped and economical, design. And so, I often feel like the people can lift way more than they think they can, but then I have to kind of balance it against what they're actually physically prepared for. So I'd say when people are new, no one's lifting very heavy and we're being really careful, but what people are capable of down the line is often where the like major surprise comes in for them.
Yeah, I agree. And everyone's at a different level. And this is sort of what we were discussing before with risk factors. So people can be I use FRAX personally. It's a calculator that will assess everyone's risk factors and sort of how vulnerable they may be to a fracture, in particular hip fracture. Assessing those areas is critical for each individual, because everyone, you can be the fit 60-year-old who's running marathons still lifting heavy weights, or you can still be the 60-year-old who can't get up out of a chair without using their hands. So I agree, everyone's at a different level there. So talking about those risks, did you want to touch any more on that, actually? More about bone biology or anything?
The risk factors would be great.
Yeah. I'm interested in unpack that a little bit more with those risk factors, because we can have someone who's already had a fracture or an injury, or we can have someone who's not had a fracture, but have high risk factors to having one. Do you maybe want to touch on stuff that's maybe non-modifiable, or do you want to? I'll check this up on it, but it's the Healthy Bones Australia chart that's recommended from the RACGP. It's for osteoporosis risk assessment, diagnosis and management, and it's recommendations from a medical perspective for postmenopausal men and women over the age of 50.
I'm just having
talk a bit more about the risk factors.
Yeah, I'm having a look at the flow chart. Looking at the risk factors. Looking at the risk factors. So there's a couple of interesting non-modifiable ones there. So just being over 70 is a risk factor, which I think is important. People know that. Having a parent with a hip fracture, I actually don't ask patients that one. I have that, so that is a risk factor for me. And then there's a lot of diseases or conditions that put you more at risk. I suppose they're non-modifiable. it's sort of a bit grey area because there are things I guess you can't. There are things that you might be able to lifestyle your way out of and things that you can't. Did you want to go through all of them? The list there?
Yeah. I would just touch on it. I mean, a couple of them we've sort of mentioned already, but talking about low muscle mass and body weight, and physical activity. But yeah, maybe we'll just touch on a couple of them if you want to start.
I'm just going to look at the diseases and conditions first because I kind of put them in non-modifiable risk factors mostly. So if you've had early menopause, I think that's defined as, I think average age for menopause is 50. I think early is considered like before 45 maybe.
Yes.
And hypogonadism, like low sex hormones.
Mm-hmm.
Celiac disease, I reckon these are so important for people to know because it's basically like, okay, if you have celiac disease, rheumatoid arthritis, primary hyperthyroidism, diabetes, chronic liver or moderate to severe kidney disease, myeloma, HIV, or if you've had organ or bone marrow transplant, automatically, they're all risk factors. So many people have any of those. And so I think just knowing that, okay, if you've got one of these things, you're at higher risk is important. And then there's also, glucocorticosteroid use for more than 4 months. And some of those, it's talking about certain medications. I guess I just think of them as like, lots of my clients refer to them as like estrogen blockers. Like I think often if you've had breast cancer, for example, you get given certain medications that then try to block estrogen, which are direct risk factors. So to me, those are mostly non-modifiable. So it's like, okay, they're just risk factors that exist and you can't do a great deal about them. The modifiable risk factors are the ones where we can have some impact, but it's important to know about both so that people know whether they're at risk or not.
I agree because just those diseases and those conditions that you just mentioned, like some of those conditions will be treated with certain medication that then sort of detrimental to their bone as well. And like you sort of said, oncology patients or people with respiratory disorders and they're taking excess amounts of steroids. The thyroid ones, very, very important. Yeah, a lot of these people, even on PPIs, people are taking them, and it's just that, they're taking it for certain other reasons. For those diseases or conditions, but then not knowing the effects that it does cause on bone. So if that is certain patients, then they need very regular routine screening or DEXA scans often to assess where they are.
PPI, proton pump inhibitor, that's like is that like omeprazole or like Nexium, like stomach acid suppressant type ones?
Yeah.
Yeah, and I do have patients all the time that find out about that later. Like they've already got osteoporosis, osteopenia, and they go, oh, it turns out this thing I've been taking my whole life is a risk factor, and like they just didn't know. So it's good to talk about it. And then I guess you get those people as well who they're about to start on a medication that they know is going to compromise bone density, and to the doctors get them a DEXA scan first just to check, can we give you this medication? And that's actually how I've got a lot of people coming to me as well, because that's the first time they've discovered that they actually do have a bone density concern. Yeah.
I agree. And all the other stuff that's modifiable is, I know some of them go in hand in hand with those diseases and conditions, because you might see someone who's celiac and they've got gut malabsorption issues and they've had it their whole life, but someone could also be celiac and be severely overweight as well, where they're not then absorbing as much nutrients. So there's other things there that should be addressed. I mean, starting with a health professional like one of us or the GP and asking more questions. I think sometimes it's the patient's responsibility to ask more about those lifestyle factors, or if they have a certain condition, how it will impact them. But stuff that's modifiable, the smoking and drinking, should be cutting that out. I think I have a few patients who just went cold turkey on alcohol and just completely cut it off. But, one wine or one beer every now and then for social reasons, I don't see too much of an issue with.
Yeah.
Vitamin D insufficiency is somewhat of a big one here in WA just because of how harsh the sun is. UV rating, but certain exposure times is quite good. The protein, calcium, malnutrition is a big one. I think that's certainly modifiable. People can be consuming a lot more protein and calcium, especially post-exercise routines. I think it's quite important for absorption. And then all of those sort of come together when you are doing a physical activity or exercise regime. That will improve body weight, that will improve muscle mass, and put you at probably mitigate your falls risk and improve your balance. So they're definitely factors that we should be screening for, or patients should be trying to improve.
Yeah, I think the Canadian guidelines have specifically in there something like a BMI of less than 19 is a risk. and maybe even like body weight under 60 kilos. Like it had actual numbers on there.
Yeah.
And I think that's interesting too, because I think it's sometimes helpful to people to know, because, you know, you've got this like fit lady coming in and she's essentially like, often they've done everything right, but they've got osteopenia or osteoporosis, whatever, but they're like a 50 kilo, fine, sort of small framed person. And I think sometimes it can be helpful to go, hey, did you know that like actually just you're in a smaller body and a smaller skeleton, like that actually is a risk factor. You can't do anything about it. Because I think often people feel really guilty. And I like to, especially people that have like done heaps of things for positive for their health across their life, I do kind of like to say to them, hey, actually, like you can't help the fact that you've always been below 60 kilos, you know, like it's just the way you were born.
Of course.
And I find that often those older adults who are smaller really struggle to eat anymore. But I do think a perfect, like you just said, after training, a perfect thing is to like introduce a snack after coming to the gym that is calcium and protein, like high protein yogurt. I feel like that's just such an easy go-to. So I do, you know, people that are able to have yogurt, I often suggest that to them as an option, because I find that they struggle to eat more, but that's something they can kind of easily fit in.
I agree. Definitely agree. The other part of the risk factors is, it's not mentioned on there, but just comes to mind, is anyone who's fallen and, you know, maybe say above age 30, 40, put your hand out to brace a fall. And you put your wrist out and to brace a fall, or you land on your hip and you fracture your hip, or you land on your bum and you fracture the spine. If you've had a fracture from a fall and you're probably above age 30, 40, even if you're postmenopausal and you're, you know, above age 50 as a female, definitely think you need to be having a DEXA scan and investigating that a little bit more. There's no reason you should be fracturing unless your bone mineral density or the quality of it is very low. So any type of trauma, injury that's sustained in a fracture, we should be establishing a DEXA scan for a baseline at least, if not, you've already had one. And that sort of unpacks that a little bit more there. It's talking about T-scores. Sorry, you're going to say something?
Oh yeah, I was just going to say, like, when you're looking at that document, we're looking at the one for GPs, like, you know, all those things talk about minimal trauma fractures. So they're talking about fractures from something really small, but I think you're completely right, and that often you will get people that are on the younger side and they've had a fracture that didn't really classify as minimal trauma, as in like they might have fallen not from standing height, they might have fallen off something, you know, there might have just been something about it where they've done something that was perceived at the time to be big enough to cause a fracture. Like I've definitely had a number of patients who, you know, they hadn't had any fractures, except for this like thing that happened, but I broke my arm doing this thing that was perceived to be big enough to break an arm. And then 10 years later, they find out, you know, now they've got osteopenia. But I reckon exactly what you said. If you're having a fracture at all, it's worth getting a DEXA scan done, because, I reckon heaps of the time people are getting fractures from things, and I'm thinking, wouldn't have thought that would have fractured if you had healthy bones. Whereas it tends to be just if it's vertebral or hip and it's like really, really obviously minimal trauma, like sneezing or something, that people go down that route. So I think any fracture.
Yeah, exactly. Because this is essentially saying if you're over age 50, you have a minimal trauma fracture at hip vertebral or other sites. So let's say you're over age 50, and I had a patient recently and walking the dog, and the dog was playing and tripped over the leash, put the hand out, fractured your wrist. So she's above age 50, she's had a minimal trauma fracture at another site, had a DEXA scan, and then her DEXA scan was at minus 1.9, sorry. And so into this category now, their recommendation from a GP perspective is now just treat that with medication straight away, which I find quite interesting. You know, she's only just above age 50, and that's you know, an outcome. So I feel like maybe this box needs to be unpacked a little bit more, and probably it mentions it at the bottom as standard practice for all outcomes, but it just says, you know, implement fall prevention strategies, encourage weight bearing and resistance exercise, modified diet, smoking and alcohol, which I feel like that's easy just to say, you've had a fracture, take this medication, go exercise. That's probably the summary they may receive, which I sometimes feel needs to be elaborated a lot more to a patient.
Yeah, definitely. And it's interesting how all the guidelines are a bit different, because I feel like the Canadian ones that have that flow chart, I think they're a little bit different.
Yeah.
But I
Maybe we'll do
suppose
another video one time comparing the UK, the Australian, and the
Yeah.
Canadian guidelines. So that'll be interesting. They've all got some great researchers and people on the boards who are writing these guidelines for us to implement. But it's interesting how those finer details do differentiate.
Yeah, and I think it is really tricky looking at like this one. There's so many patients of mine this applies to where they had a minimal trauma fracture not at hip or in spine, so it was at another site. So I'm thinking wrists and ribs, and tibia plateau, yeah. They got their DEXA scan and their T-score was better than 1.5, so like minus 1.1, say. But then so it's sort of say investigate other causes for fracture. But it's like,
so now then that's pushing them back down the other path to investigate, do they have other sinister pathology or any other diseases that's maybe been missed throughout their life. So I've got a feeling, because one of the GPs I work with had this similar case, and then they go on to have blood tests to check for other things, and they find out they've got thyroid issues, or they find out they've got diabetes. That's normally how that goes from what I've experienced. But sometimes they come to a dead end and there's no other cause for a fracture.
Yeah, I feel like my clients have had sort of the whole spectrum, but I'm just forever curious that T-score alone, it's so not as predictive as you'd think it would be for who's having a fracture and who isn't, because some of my ladies with the worst T-scores have never had fractures and can do sort of very high, difficult forms of exercise. And I'm actually think most of the ones who've actually had a fracture are sort of the ones that are like the younger, fitter, better T-score clients. And it's probably, it's totally biased sample, just my own clients. But yeah, it's just interesting to read through those guides.
Yeah, and yeah, I agree. That's common more than ever lately. Seeing lots of people like that, and they're having the same issues. So I was just saying that other clients just get a bone mineral density scan, and that's your sort of risk factor assessment. That's what we were sort of touching on before, that it needs to be unpacked a lot more with a health professional. And there's other scans that may be available, like peripheral QCT or REMS, and all these other scans coming to the market now that's assessing bone microarchitecture, which I think is great. But until it's more accessible for people, or Medicare funded, there's certain things to assist these patients and awareness to the GPs, then right now I still think DEXA might be the best way to go.
I do find that once people, a lot of my clients have just gotten their first one because they've just hit 70 and it'll be covered by Medicare. And quite surprisingly, a number of them are osteopenic. I said, like, I'm surprised they're surprised because they don't necessarily have the risk factors. And it just more and more, it just makes me think, wow, like how many people have it and they don't know.
Yeah. And that's the thing that sort of digress a little bit, that frustrates me with the PBS subsidy currently, is that you need to have had a fracture due to osteoporosis, or you need to be over age 70 with low bone mineral density, e.g. had a DEXA, or you've been taking steroids or prednisolone, any other type of heavy steroid for the past 3 months. And that's just ridiculous. It's like, let's wait until something happens, or you're above 70, or you've been on medication for some time before we do something about it. Yeah, it frustrates.
So having one of those risk factors alone isn't enough? Like having celiac and being 60 you can't get it funded?
No, you can't. And this is what I'm saying. So people who are above age 50, 60, and they've got these risk factors, they should be taking it upon themselves, or pushing their GP to send them for a referral to get a DEXA scan as a baseline. And it might be $100 to $200 depending on where you go. That would be out-of-pocket expense, but I think it's a great starting point that can, if you find that out at 60 or 50, and you've got 20, 30 years to work on bone mineral density, bone quality, bone strength, then you can put yourself in a better position.
Yeah, definitely.
All right, so yes, as much as some of that's frustrating that Medicare doesn't support everyone, but I think it might be worth another conversation another time to unpack that, and we can talk about Medicare and other things. So thanks for your time again. We'll touch base shortly.
Awesome, thank you.
All right, see you. Bye.
Bye.